So, the other day I went to fill air in my tires at the garage, and the attendant told me that they're going to start charging for filling air in tires. And I was amazed. I said, really? What do you mean you're charging for air? He said, no, man, it's inflation. And with tomorrow being Father's Day, ever wondered why they hardly celebrate Father's Day in Egypt? Because there's too many mummies there. Hello everybody, it's Ryan here. I hope you and your folks are well. Today we're talking about a very topical subject, gout and hyperuricemia. This is the outline of our talk. We're going to be covering a clinical case for some context. We're going to be looking at gout in terms of introduction, etiology, patient presentation, signs and symptoms, differential diagnosis, diagnostic evaluation in terms of investigative workup, treatment and management, prognosis and complications, and we're going to end up talking about the Bible. Thank you so much for joining me. Hope you and your family are well. Let's get started, guys. Here's our case. Mr. Crystal is a 72-year-old man with only a history of hypertension on our beloved hydrochlorothiazide, otherwise called RUDAC. He presents today with acute excruciating knee pain. Oh dear. On examination, his knee is warm, mildly erythematous, swollen and tender to touch, and on passive movement. Microscopic examination of joint fluid is shown on the next slide. Now, which of the following is Mr. Crystal's most likely metabolic derangement? Is it A, an acute bacterial joint infection? Is it B, antibodies to anti-nuclear antigens? C, hyaline cartilage degeneration? Is it D, increased production of inorganic pyrophosphate? Or is it E, uric acid overproduction? This is the picture of the crystals in his fluid. Thank you so much. Guys, gout is a metabolic disorder in which hyperuricemia leads to the precipitation of monosodium urate crystals in joints and other tissues, resulting in inflammation, tissue injury, tophi, and arthritis. The most common presentation is what we call podagra, which affects the first metatarsophalangeal joint, but you can also have inflammation of the knees, ankles, and wrists. The greatest risk factors appear to be some medications, weight gain, and alcohol use. Gout has been dubbed the disease of kings because it happens in people who eat a lot of red meat, drink a lot of alcohol, which contributes to purines, which actually underlies the pathology of this crystal formation in the joints. Unusual presentations may occur among women, young men, and post-transplantation patients who are taking cyclosporin. Now, similar disorders include a brother of gout called pseudo-gout, in which we have precipitation of crystals, but it's not monosodium urate crystals. In pseudo-gout, it is calcium pyrophosphate crystals and other crystal deposition disorders like calcium hydroxyapatite and calcium oxalate. Okay, let's talk about etiology, epidemiology, and risk factors. Hyperuricemia is defined as a serum urate level exceeding 0.35 millimole per liter. That is the key cut point. Serum uric acid exceeding 0.35 millimole per liter. Now note that not all hyperuricemic patients will develop gout. About 2/3 will remain asymptomatic. Higher levels of serum uric acid and longer durations of exposure increase the risk of progression to clinical gout. In general, gout develops after about 10 to 20 years of sustained hyperuricemia. In post-transplant patients, gout tends to develop quicker, often after about 2 to 5 years. Most cases, upwards of 90%, occur due to decreased excretion of uric acid. Example, patients who have chronic renal disease, low volume states, and diuretic use already. The remainder of cases occur due to excess production of uric acid. This may occur due to certain genetic enzyme defects like what we call HGPRT deficiency or phosphoribosol pyrophosphate PRPP synthetase overactivity or increased cell turnover. Example, leukemias, psoriasis, and hemoglobinopathies. Many drugs also alter uric acid metabolism, including thiazides and other diuretics, cyclosporin, aspirin, alcohol, and lead. Predominantly a disease of men, because estrogen is actually thought to increase urate excretion in women, kind of protective against gout in the females, right? So women are lucky there. Ha ha. Risk factors include family history and age above 30, females post-menopause, particularly those on thiazides, because post-menopause, the protective effect of estrogen is lost, right? Alcohol abuse, obesity, and lack of exercise. How do patients present, guys? Nice to ask. Acute gouty arthritis is where we have repetitive attacks of severe joint pain, swelling, and erythema. And we already spoke about podagra, which involves the first metatarsophalangeal joint on the feet. And that is probably the poster child in terms of presentations for gout. Also commonly involved are the ankle, the knees and wrists. Fever may be present. Recurrent oligoarthritis with each episode initially lasts 5 to 7 days. And there's a so-called intercurrent period which may occur, during which symptoms of arthritis are absent, but uric acid continues to accumulate and tissue deposition continues. Ultimately, chronic topaceous gout occurs after a long-standing grumbling period of 10 to 20 years, presenting with palpable tophi in the subcutaneous tissues, periarticular areas, bone, and pinna of the ears. Here's a beautiful cartoon from McComic.com. A big thank you to Mr. Jorge Muniz and company, illustrating the key differences between gout and its brother pseudogout. So in gout, we said that the underlying pathobiology is uric acid, monosodium urate or uric acid crystals. The most common site is at the first metatarsophalangeal joint called podagra. We have eventually in the chronic form topaceous gout, which is the formation of tophi at the joints. And if you look at this finger with some crystals in its bum here, negatively birefringent needle-shaped crystals on polarized light microscopy, right? And then the finger or the toe is asking, why do bad things happen to great toes? Pseudogout. Pseudogout is a bit different, guys. This usually targets the larger joints, such as the knee. The underlying pathobiology is not monosodium urate crystals, but calcium pyrophosphate dihydrate crystals, CPPD. Chondrocalcinosis is what you can appreciate on the radiographs, and opposed to being negatively birefringent, as in gout, these are positively birefringent rhomboid-shaped crystals on polarized light microscopy. Thank you so much, makecomic.com. Okay, this is a typical presentation of podagra. We can see the first metatarsophalangeal joint being involved here because of deposition of monosodium urate crystals in acute gout. Alrighty. Here is gouty tophi in the fingers. We can appreciate that. Here is gouty tophi in the olecranon bursa. Okay. Remember that the musculoskeletal manifestations of crystal-induced gout include the couple to mention. Let's just get my pointer in there. Acute arthritis, which is episodic, which can manifest with mono, oligo, and polyarthritis. So mono means 1, oligo means 4 and or less than 4. Polyarthritis is 5 or more, right? Periarticular inflammation in the way of bursitis, tendinitis, enthesitis, topaceous deposits. Chronic arthropathy in the way of destructive arthropathies, chronic inflammatory arthritis, and peculiar types of osteoarthritis. Spinal arthritis and carpal tunnel syndrome. Okay, guys, let's look at the differential for gout. Acute monoarthritis has a whole truckload of differentials, right? It can be septic arthritis, gonococcal arthritis, Wright's syndrome, which is called reactive arthritis. It's a group of the seronegative spondyloarthropathies, Lyme disease, trauma, pseudogout, and of course, everybody's favorite, osteoarthritis. The current monoarthritis differential includes palindromic rheumatism, spondyloarthropathies, pseudogout, and osteoarthritis. Differential for polyarthritis includes rheumatoid arthritis, psoriatic arthritis, Wright's syndrome, and osteoarthritis. Remember that tophi may actually mimic the rheumatoid nodules, right? Or subcutaneous nodules that we have in rheumatic fever. So watch out. That's a nice differential. Cellulitis is another differential, right? Guys, how do we work up somebody who has, or somebody who you suspect has gout? First up, the basic tenets of medicine are history and physical exam, right? So take a good history, examine properly, and you find that your findings are going to be consistent with acute inflammatory arthritis, right? And if you aspirate that synovial fluid or the tophi, what we find is diagnostic, right? Synovial fluid aspiration reveals negatively birefringent needle-shaped crystals in polarized light microscopy and between 60 and 90,000 white cells per cubic mil with more than 70% pleocytosis of neutrophils. The key word is polymorphonuclear leukocytes, all right? Aspiration of tophi shows urate crystals. Serum uric acid levels not always correlate with clinical gout. Remember that. 24-hour urine uric acid levels may help to distinguish overproducers from under-excretors, right? Please note, it is useful in patients with renal failure or chronic diuretic use. X-rays will reveal our beloved punched out lytic areas with overhanging edge. Punched out lytic areas with overhanging edge. Okay, guys, this is the ACR-EULAR criteria 2015 diagnostic criteria for gout. So we can say that, let's just get my pointer in there so we can talk business. Okay, we look at the pattern of joint involvement. It's usually the ankle or midfoot. You get 1 point for that, and podagra, you get 2 points. Then you look at the characteristics, right? Erythema overlying the joint, cannot bear touch or pressure, difficulty walking or using the joint. If you have one characteristic, you score 1, 2, you score 2, 3, you score 3, right? Time course of the typical episode, right? If it's maximal pain within 24 hours, resolution of symptoms within 14 days, and complete resolution between attacks. If you have one typical episode, you score 1. Recurrent typical episodes, you score 2. If you got clinical evidence of tophi, you score a whopping 4. Serum uric acid level, if it's below 0.24, you actually subtract 4 from that. Right? If it's between 0.36 and 0.48 millimole per liter, score 2. Between 0.48 and 0.6 millimole per liter, score 3. If it's above 0.6 millimole per liter, you score 4. On synovial fluid analysis, if you are monosodium uric crystal negative, that's actually -2. Imaging, right? If you got ultrasound detection of tophi or X-ray showing erosions, these are present, you score 4. I think corporate score of 7 or more indicates gout. Alrighty, thank you so much. This is some beautiful images demonstrating aspirate of synovial fluid in patients who have gout. Alright, let's just get my pointer in there. So picture A is extracellular and intracellular monosodium uric crystals as seen in a fresh preparation of synovial fluid. Illustrate needle-shaped, positively birefringent. Birefringent means 2 colors that you can see, right? Purple and yellow under polarized light microscopy. And here we see pseudogout. So as opposed to being in picture B being pseudogout, because there's rhomboid-shaped positively birefringent crystals as opposed to negatively birefringent needle-shaped crystals in gout. Thank you so much. Okay, guys. How do we treat and manage gout? Nice to ask. So first up, you want to discontinue all your offending drugs if possible and attempt to correct contributory lifestyle habits such as excess alcohol use, obesity, and lack of exercise. Acute gouty arthritis can be treated with first up bed rest and ice. Then you can use indomethacin and non-steroidal anti-inflammatory drugs. One of the kingpins in treatment of acute gout is the good friend, the Rolls-Royce, colchicine. Initially, we give 0.5 to 1 milligram, followed by 0.5 milligram every 2 to 3 hours until the pain is relieved or GI distress develops. Do not exceed a ceiling dose of 6 milligrams, and a course should not be repeated within the next 3 days. Okay, corticosteroids may be used in severe disease. Then they can be given orally, intramuscularly, intravenously, or intraarticularly. Right? Avoid hypouricemic therapy with allopurinol and diuretic use during acute attacks. You want to treat the inflammation first and then reduce the uric acid level. Okay. Recurrent attacks of acute gout, being more than 3 episodes per year, suggest the need for chronic prophylaxis. Right? Allopurinol, as we said, decreases production of uric acid. The dose orally initially is 100 milligram daily as a single dose. You can uptitrate by 100 milligrams weekly, depending on the response as reflected by plasma and uric acid levels. The normal dose we give is about 300 milligram daily, up to a ceiling dose of 900 milligram daily, right? Watch out, because in renal impairment, we need to dose reduce the allopurinol, not because it's nephrotoxic, but because it's excreted in the kidneys, right? So if the creatinine clearance is between 10 to 20 milliliters per minute, we want to drop the dose to 100 to 200 milligram per day. If creatinine clearance drops below 10 mils per minute, we want to give at most 100 milligram per day, or you could increase the dosing interval. Treatment should be withdrawn if the patient develops a skin rash or fever, as these symptoms precede a serious hypersensitivity reaction. We know that allopurinol can cause severe hypersensitivity in people who are genetically predisposed and have the beloved genotype HLA-B5801, which predisposes to DRESS syndrome, drug reaction with eosinophilia, systemic skin manifestations, DRESS. Okay, uric agents, the likes of probenecid and losartan, decrease renal absorption of uric acid and may be effective in under-excretors if tophi are absent and renal function is normal. You want to avoid these in patients who have a history of renal stones. Lifestyle changes may be effective, including weight loss, abstinence from alcohol, and reduction in red meat consumption. Milk consumption appears to have some kind of uric effect, thereby causing a reduction in serum uric acid. Chronic trapezius gout is treated with allopurinol to decrease the production of uric acid. You want to avoid in patients using azathioprine, 6-mercaptopurine, and trimethoprim. And we know trimethoprim sulfamethoxazole is Bactrim, right? Febuxostat may be preferred in patients with renal insufficiency. You want to titrate the dose of uric acid to achieve levels of 0.33 millimole per liter in non-trapezius gout and attempt target of 0.3 millimole per liter in tophaceous gout. So our targets, guys, remember our targets for uric acid level is to achieve a level of 0.33 millimole per liter or less in non-tophaceous gout. And in tophaceous gout, our target is 0.3 millimole per liter or less, right? Here's a beautiful diagram from Harrison's illustrating the pathogenesis of gout and appropriate targets. Let's just get my pointer in there. So metabolic and some genetic factors contribute to the development of chronic hyperuricemia. Gout, as you know, stems from an increased body pool of urate due to chronic hyperuricemia, leading to supersaturation and crystal formation and deposition of our beloved monosodium urate crystals within the joints and connective tissue. Synovial tophi are usually walled off, but certain triggers may loosen them from the organic matrix, leading to crystal shedding and interaction with synovial cell lining and residential inflammatory cells, initiating an acute gout flare. Okay. So this is basically when you have a normal urate level. And in gout, obviously, if you have risk factors like obesity and insulin resistance, metabolic factors like diet and alcohol, too much red meat, genetic predisposition, certain medications like diuretics and low-dose aspirin, and cardiorenal conditions, you can have chronic hyperuricemia, which increases your urate pool, right? This will then lead when exposed to certain pathophysiological factors like high urate temperature, pH, intra-articular dehydration, cationic concentration, collagen, chondroitin sulfate, non-aggregating proteoglycans, to monosodium urate crystallization, crystal growth, and tissue deposition. Okay, this can then lead to recurrent gout flares and acute crystal-induced inflammation, right? Certain triggers include metabolic triggers, diuresis, rapid changes in urate levels, local trauma, medical illness, etc. And that eventually, if it goes unchecked, will lead to chronic gouty arthritis and a crystal burden sequelae. Anti-inflammatory therapy, the likes of non-steroidals and colchicine and glucocorticoids, will obviously treat the recurrent gout flares. And the urate lowering therapy, you said like allopurinol, febuxostat, probenecid, uricase, will act to increase your uric acid levels to our targets. Remember, our targets are in non-tophaceous gout 0.33 millimole per liter or less, in tophaceous gout 0.3 millimole per liter or less, guys. Okay, let's talk prognosis and complications. Acute attacks are often triggered by trauma, stress, surgery, illness, alcohol, diet, or abrupt changes in uric acid levels, guys. Tophaceous gout can occur in rare areas, including the conduction system of the heart, beware, causing heart block. Skin tophi can ulcerate and become infected. Remember, guys, gout is a major cause of morbidity in post-transplant patients, particularly after cardiac transplantation. Preventive treatment is best via modification of risk factors, okay? Alrighty, coming back to our clinical case, let's just rehash this. You got an elderly gentleman, 72 years old. His name is Mr. Crystal, haha. Known hypertensive on hydrochlorothiazide, comes with acute excruciating knee pain. Clinically, his knee is inflamed, is warm, is tender, erythematous, diminished range of movement. You know the 5 things: rubocala, dola, tumor, functio, lesa. Rubocala, dola, tumor, functio, lesa. The 5 things which indicate inflammation, all right? Microscopic examination of joint fluid shows our beloved needle-shaped, negatively birefringent crystals on polarized light microscopy. This is gout, 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 gout. And the answer here is that this gentleman has uric acid overproduction. So the micrograph illustrated extra and intracellular monosodium urate crystals having needle and drop shapes. They are negatively birefringent, and that is gout. Most likely this gentleman is an overproducer of uric acid. Okay, my friends, please allow me to spend a few moments talking about the Bible, and we're going to be talking today about living with eternity in perspective. The book of 2 Corinthians chapter 4 verse 18 says, "So we fix our eyes not on what is seen, but on what is unseen. For what is seen is merely temporary, but what is unseen is eternal." The Lord Jesus tells us to not store up treasures for ourselves on earth, where rust and moth corrode, where thieves break in and steal, but rather we should store up for ourselves treasures in heaven. We can truly be happy when we fulfill God's purpose and will for our life. And this life, my friends, is just a small dot in comparison with eternity. We should always live with eternity in mind, and not just live for the here and now, but live with eternity on our mind. And the only way to eternal life is through belief in the Lord Jesus Christ. John 14:6 declares, Jesus says, "Behold, I am the way, the truth, and the life. None comes to the Father but by me." John 11:25 as well declares, "Behold, I am the resurrection and the life. He that believes in me, even though he is dead, yet shall he live. And he who lives and believes in me shall never die." And I pray we will always have this perspective in our minds. All right, these are my references. Guys, if you enjoyed this content, I encourage you to smash that like, subscribe, and share buttons. Right? And you can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on Instagram and on TikTok as well. Looking forward to your friendship on those platforms. God bless you. We'll be tackling a lovely topic coming up, inflammatory bowel disease. Looking forward to seeing you then. Alrighty.